All right, let's get started. Okay, so we've got a few questions for this week, so let's get started. Number one, I have a 10-and-a-half-year-old who has an upper stage 1 retainer and lower stage 1 wearing passively as the D's and C's are changing over. The upper E's is starting to get loose. I plan on scanning for upper stage 2 in 2 weeks because we need to hold the leeway space. When will he be wearing the upper stage 2 appliance full time? Doing go pecs and go fecs and froggy mouth without plates in. At what point do I wean him night time? So if you need to hold leeway space and the E's are starting to get loose, then you need to move to wearing the stage 2 as quickly as possible. If you haven't started GoFX and Froggy Mouth, then the plates are still worn full time until we have control of GoFX. So if you're planning to use Froggy Mouth and GoFX, then the stage 2 needs to be worn all the time until competency in the GoFX is reached. Only when competency in GoFX is reached do we move to wean out of daytime wear. GoFX and Froggy Mouth are all done without plates in the mouth, so the transition will be wearing no plates when doing the exercises, GoPex and GoFX and Froggy Mouth, but wearing the plates at all times other than the exercise period. When they can demonstrate to you, they can do the sip, swallow, click exercise correctly. At that point, we start to move away from full-time wear. Okay. Second question. I have a case we are working on with a deep bite and laterals erupting. We are using upper cat wires to try to intrude and procline upper centrals into a bed arch form with the laterals and the canines. So our current plan is to determine if we need to bracket the upper C to C, depending on the overbite we have after proclining centrals to the level of the cuspids. Question, would you still bracket the laterals before they fully erupt? Crowns are still short as the gingiva is positioned incisally. It would make more sense to bracket them before they over erupt. I just don't know when we bracket them. So it's more awkward, more difficult to bracket teeth when they haven't, and when the crown isn't fully emerged. We make that decision based on how much reduction of overbite you need. If we are looking at 75% reduction, then they are over erupted, and so they need an intrusion component. When you're controlling over erupted incisors with limited brackets in the postural orthodontic process, you're going to be bracketing the incisors close to the edge, but the primary canines close to the gingival margin. So obviously you can't bracket any teeth that aren't fully exposed in the crown, at least to 2/3 mark, otherwise you can't get your bracket in place. Bracketing also tends to create a retractive force. So until you've confirmed you've got enough room for the lateral incisors and procline the central incisors to reduce that overbite, then you're not going to be bracketing the lateral. So generally, we don't bracket teeth until they're at least 3/4 erupted through the crown. And you have controlled, until you've also achieved the transverse development that you need. So in postural orthodontics, the bracketing component is considered the dental tidy-up component or the orthodontic component. In postural orthodontics, we do skeletal arch form development first, and then we do the tidy-up. So the general sequence is we do the transverse development first, then we work on sagittal development by tipping retrocline teeth, which tends to be part of the overbite relationship issue. Once we've got the correct arch form, only then do we look at tidying up the incisors. So that's kind of like the last step in that process. All right, next question. There is an increase number of cases of overweight children here due to diet, lack of exercise, sleep, and addiction to headphones. The parents are often too busy working and leave the supervision of children to schools, daycare, nanny, or relatives. My few cases of myofunctional appliances and myofunctional therapy, including GoPex, are facing difficulties of compliance due to this lifestyle. The children are being driven to school and then daycare, then relatives' houses, and back home at 11 p.m. The appliances go missing in action within weeks. What is the first step if parents are eager for treatment? How do we explain this to parents? Do we have to refer to dietitian or weight management practitioners or lifestyle coach? What are the special instructions for compliance for these groups of children and parents? What do we have to look out for during treatment, the possible problems and solutions? Okay, so one of the tenets of postural orthodontics is that we use compliance-based therapy. Okay? So fixed orthodontics is what we would classify as non-compliance based treatment, where there's no need for any input from the patient nor the parents, other than turning up and paying the bills. From postural orthodontic perspective, we predominantly use removable appliances and we use exercise programs for retraining of posture and to a less degree function. So the compliance component is overriding. So in compliance-based therapy, treatment success is almost entirely dependent on compliance. So if you have parents that are eager for treatment, you explain it to them in that terminology. The success for early intervention using postural orthodontics is based on compliance of wearing and safeguarding removable appliances and performing the instructed exercise protocols according to the instructions. Failure to comply will indicate an overwhelming likelihood of failure for the treatment process. If the instructions aren't followed to the T, then the treatment will fail. So that's basically how you answer question 1 and question 2. So if we're keen to participate because we want the outcome, then the outcome is only possible if we participate. If we don't follow the instructions, if we don't wear the plates, if we don't safeguard the plates, we don't do the exercises, the treatment will fail. And so that's how you explain it. Then you finish with, are you good with that? If you do what I ask you to, the way that I ask you to, when I ask you to, then the treatment will have a good chance of success. If you miss even one of the instructions and don't follow to the letter my instructions, then the treatment will fail. Are you good with that? So that's how you explain it. Do we have to refer to a dietitian or weight management practitioner or lifestyle coach? So from the perspective of being a dental clinician, we aren't involved with diet outside of how it affects the dental and oral health. So we aren't involved in lifestyle, we're not involved weight management, but we are involved with caries control and periodontal control. When we are managing postural orthodontics, we focus on the mechanical component of mastication. We're less involved in the dietary intake. That said, from a holistic perspective, as a health practitioner, there's no downside of suggesting that diet could be improved, that weight management could be improved, that lifestyle can be improved. And if you feel like you would like to help the family manage their diet, their weight, and their lifestyle, then seek the services of healthcare providers who specialize in diet, weight management, or lifestyle. And by all means, refer or suggest they tidy up that aspect of their life to help with the management of the oral health and growth and development. Right. So it's a common sense approach. You can play it safe by suggesting rather than insisting. The stronger your collaboration with dietitians and lifestyle coaches and weight management clinicians, then the more insistent you can be if you feel in your experience that that component of healthcare is beneficial. So just like we don't treat sleep disorder breathing, just like we don't treat general health issues, just like we don't treat attention related issues, psychological related issues. It does mean that we don't observe, look out, and screen for those issues and make appropriate referrals to the appropriate clinicians. So, diet, weight management, lifestyle, work with people that you feel have the same philosophical lean as yourself, and you're welcome to make suggestions. You're welcome to refer formally. Right? You can write a letter of referral to dietitians, to lifestyle coaches, to physical therapists, physiotherapists, and um, gymnastic instructors, whatever you like. Um, refer through suggestion, or you can refer formally, as you would any specialist. What are the special instructions for compliance for these groups of children and parents? So the special instructions are: the success of this treatment depends on the child wearing the plates all the time, caring for the appliances as if they were a special, important part of their life, and doing the exercises under the supervision of a parent. That's the special instruction, or a responsible adult. That's it. That's the special instructions. If you understand the concept of responsibility as a guardian to a child, then you don't need someone to explain to you what you need to do. You just have to decide if this is what you want for your child, then you will supervise the child's care according to the instruction of the provider. If you don't understand the concept of guardianship towards the child, then it doesn't matter who explains it to you, you will never understand it. As an adult, if you don't understand the concept of guardianship of a child, where the responsibility of the well-being and the development of that child is your care, your responsibility, then no one can explain it to you, because you've reached a point in your life as an adult that you either understand it or you don't. What do we look out for during treatment? The possible problems and solutions. Well, if the plates go missing all the time, if you ask them have they done the exercises and they say no, or they don't answer you, then you know that they're not following your instructions. If you don't get an affirmative response that they're following your instructions, and if the clinical awareness that you have that the appliances aren't being worn, the appliances are being lost, and they can't demonstrate to you competency in performing the exercises, then you know that you've got a problem in your hands. But this is a contractual agreement, right? You make your case, tell them this is the plan, this is what I need from you, this is what I need from your child, this is what I need from you as parents. Can you fulfill those requirements in order for me to fulfill my promise to deliver the result that I would like for your child? If you can't agree to those terms and conditions, then it's best that we don't treat. All right, 7.5 year, just losing primary central incisors, but presenting as a class 2 relationship. We recommend it in general. We make small adjustments to the cat wires as the case goes along each appointment to maintain best control. But for a case where there's an excess overjet in this situation, would you keep the cat wires back from the primary incisors and permanent incisors as they erupt, so as not to encourage them to erupt any further facially, which would increase the overjet? Or would you continue to focus on the fact that the upper arch still needs expanded to fit all the incisors and canines, therefore continuing adjustment of upper cat wires up against the gingival margins at each point? So obviously it depends on what you're presenting with. So if you've got a severe class 2 division 1 relationship at the beginning, and the incisors are already out in the middle of nowhere, then you don't want to keep developing them forwards. So you would consistently adjust the wires so that they don't touch those incisors. Right. So every session you're adjusting the cat wires to either engage or disengage. All right. So you control the plate, don't let the plate control you. So each case is dependent on the situation. In a Division 2 relationship, when the incisors are retroclined, then you want to keep adjusting the wires so that they're applying very minute pressure to retrocline teeth. If the teeth are excessively proclined in the Division 1, then you don't want them to go any further forward. So you're constantly adjusting the wires so that they disengage from those teeth. So irrespective of whether you're constantly engaging or disengaging, you're constantly making adjustments so that you have control. That's the whole point. You are controlling the process at all points in time rather than letting the plate and the parent's expansion process dictate terms to you. You dictate the terms of the treatment. 8-year-old with a severe anterior crowding and significant retroclined lower incisors. As we start expanding and procline the anteriors and then place brackets to level the line and bring incisors facially. Clinical crowns on the lower centrals are looking very long, like recession is imminent. How do we manage this other than going slow and warning parents that they may need grafting? What is the clinical outcome we should expect in these cases? I am not the general dentist and I don't want the pedodontist to get concerned. So when you have excessive crowding in the lowers in general, you will often have one of the incisors displaced buccally and one or two of the incisors displaced lingually. Commonly, the lower centrals, one of them will be displaced buccally, and commonly, one or both of the lower laterals will be displaced lingually. Teeth that are displaced buccally fall outside of the arch form and are already usually periodontally compromised because they have erupted outside of the bony envelope. When we take our initial records, we should document correctly that you have some teeth that are in the arch form, some teeth that are outside of the arch form labially, and some teeth that are outside of the arch form lingually. When you are presenting your treatment plan, you will let the parents know that the teeth that are starting buccally have risks of recession because they are developing outside of the arch form bony envelope. And irrespective of what you do, that bone may or may not ever reform itself, and there will be a potential that the periodontal health of that displaced tooth may never be as good as it should be. So your role, of course, is to make sure that tooth isn't continuously displaced forwards. And as a general rule, it won't be, but sometimes the predisposed gingival level, based on the fact that the tooth is displaced outside of the arch form, will reveal itself as the tooth continues to erupt and areas settle into their definitive positions. So the reality is part of your consent process must include gum health may be compromised because of the alignment of the teeth outside of the bony envelope of the existing arch form. So if you've been using consent forms, as I have asked you to consider doing, that's listed as a consideration. And these topics are part of consent. So the package that I offer the mentorship group is comprehensive. But not only do I teach you how to assess, evaluate, treatment plan, and carry out treatment, but the informed consent process in the documented treatment planning forms that I offer as part of the package highlight these specific areas of potential risk and concern. It's up to you to talk each of these points through with the parents before you start treatment. What are the reasons that an 8-year-old child grinds their teeth every night? Is it normal also for a 10-year-old to grind their teeth the majority of nights? So bruxing is a topic that many of us deal with on a day-to-day basis because many of our patients practice. There's no definitive answer to the etiology of bruxing, but we know that bruxing is a reflex response that is associated with stresses on the body system. Common stressors on the body system include both physical and psychological stresses. Psychological stress can be any number of issues, which is something that we all have an awareness of. You clench and grind your teeth, the gnashing of your teeth because of sadness, because of distress, because of any number of emotional responses. Right? Gnashing of teeth. It's a 2,000-year-old recording in the Bible. Bruxing of the teeth are also reflex responses commonly for airway protection at night and as a response to physical pain. Airway response bruxing is part of one of the things that we screen for because many of the children that are growing up today are airway compromised. Those airway compromised children have a protective mechanism where they clench their teeth, tighten their muscles, basically to bring some form of protection to their airway. Either tightens the pharyngeal spaces or it brings tongue out of the back of the throat, any number of responses, reactions to compromise nighttime airways. Another response would be as a reflex to pain. Commonly, children's pain comes from skin irritations and gut irritation. Eczema, some forms of skin rashes, very common. Gut irritations are very common in children, and anything that inflames, causes pain in the human being will initiate a bruxing reflex, tensing of all the motor muscles. In adults, sleep breathing disorder and back pain, joint pains, very common. In children, sleep disorder breathing, gut irritations, skin irritations, very common. How do you design the stage 2 appliance in the eruption bicuspid area? You should have ease still there when you scan, the pores are erupting, or maybe barely visible. Where do you put the canine and bicuspid wires? So we place the wires to the distal of the primary teeth. Okay, so the wires cross over at the distal marginal ridges of the respective primary teeth. And as the primary teeth erupt, theoretically, the new teeth should erupt just in front of those wires that sit on the distal of the primary teeth. So we have a sweep of the wire from the palatal side or lingual side, and then we cross over to the facial side at the distal marginal ridge of that respective primary tooth. When you ask us to evaluate the molar relationship in making decisions of whether or not to expand further, you're only referring to the permanent sixes relationship. I find the primary relationship can be really off and misaligned while the sixes look correct. So obviously, the more important tooth in question in the posterior contact is the permanent dentition. So we're trying to determine the amount of buccal overjet we have in the permanent sixes. Whether the primary molar relationship overjet is correct or not is less important than the permanent molar relationship. All right, so you have to remember when we take intermolar width, we are traditionally referring to the 6-year-old molars. So when we're evaluating molar relationships, that's the molar that we're actually interested in. If patient is wearing a stage 1 passively as a retainer full time, is it possible to lose a bit of transverse development in the molar region? Also, as they supposed to be eating with the retainer in place, even though we are not expanding as there is no screw in this retainer. He hasn't lost the ease yet, and we are bending wires to help to distalize the erupting pores. I'm getting a bit lost in the protocols for the retention phase because it can occur prior to the D's and E's getting loose or can occur after losing the E's. So can you explain the difference in retainer time during these different scenarios? Or are there some basic rules to follow that can be applied to any patient in retention phase? So retention phase is when you're no longer fiddling with anything. Retention phase is when your teeth are where you want them to be and the dimensions are where you want them to be. If you are adjusting for alignment or expanding for dimension, you are still wearing the plates full time because you can't move into a retention phase when you're still in your mechanics, or you're still in your level and aligning, or you're still in your tidy up. So the general rule of thumb is when you're done, you're ready to move to retention. When you're not done, you're not ready to move to retention. It doesn't actually matter how many teeth you have, or which teeth are changing over, or whether you're mixed dentition or permanent dentition. Retention phase is when you're holding passively what you finished providing the patient. If you haven't finished providing the patient with treatment, then you're not in your retention phase, you're still in your active phase. When you're in your active phase, you're wearing the plates full time. When you're in your retention phase, you're wearing the plates at night. There is a transition period where you're done with your active treatment and you're preparing the patient for their retention phase. That's only the time where you start weaning them out of wearing the plates gradually. And you do that according to their competency in their control, their tongue control. Right, in the active treatment phase, we're trying to help them also, when you're fiddling in the mouth, you're also training them for lip control and elevator muscle control. In the retention phase, you're effectively assumed that you've already got lip control and elevator muscle control. Now you're working for tongue control. But you can only work on tongue control when there's no plates in the mouth. When you're guiding teeth, or when you're maintaining positions of teeth, again, you are predominantly making adjustments and then telling them that they only need to wear it at night, because your adjustments are minutiae, a teeniest, tiniest little movement of wires. You can wear the plates part-time when that is happening. When the adjustments are big, expanding the screw, or you're making big changes to the alignment of the teeth, the plates have to be worn full-time for that big change in the plate to be able to fully express itself in the teeth and in the jaw system. Okay, last question. A discussion we've been having on the WhatsApp group. When you start the scans for appliances, do you start the GoPEX immediately? Or do you wait until you've delivered the appliances and are firmly confirmed ability to eat and wear the appliances full time before starting GoPEX? I found parents unable to handle both GoPEX and tolerating the appliance initially. Understand we need to follow protocols, but also want us to succeed. So we try not to jumble everything up together. Each of these processes should be kind of separate, right? Initial delivery of appliance, that first 2 to 4 weeks is a very difficult time. During that time, our sole focus should be on getting used to wearing the plates, getting used to turning the plates. There should be no forms of exercises involved unless they're pre-existing and we're already versed in the exercises. Some families, you start GoPEX before you deliver appliances because you're trying to gauge compliance. In those families, you don't start appliances until they have mastered the basics of GoPEX. In those families, they've already mastered GoPEX. You're adding in a new appliances, so you can continue with the GoPEX with the new appliances because you're only adding one new thing, which is the new appliance. For the families that are a cold start, where you judge that compliance won't be a real issue, you're going to already move straight into appliance therapy. For those families, for the first 2 weeks or a month, until they get used to the appliances, you start with just the appliances. when they've demonstrated that they're eating with them, talking with them, wearing them well, expanding correctly, at that point, you add one of the exercises in. And when they have a handle of eating and turning, wearing the plate, and accepted the burden of that one exercise, then you add the second exercise, and so on and so forth. Right? The whole point is we're adding one ball in the juggle equation at a time. Okay, fantastic. And that ends our 45 minutes for today. Fantastic, guys. Good questions.